If you're a resident preparing for your blood exams, specifically the FRCS in plastic surgery, you are in exactly the right place.
Absolutely.
Because our mission today is highly focused. We're doing a rapid-fire, high-yield deep dive into the clinical profile and management of breast cancer. We know how overwhelming board prep can be, so we're not going to waste any time today.
No time at all. We are strictly looking at the foundational facts, the critical thresholds, and the surgical pathways that you need to recall instantly. And this isn't just for the written paper. This is exactly what they want in your clinical vivas.
Right. So to make this efficient, we're doing a strict question and explanation style format. I'm going to fire off the core topics and the clinical scenarios, and we will break down the definitive exam-ready answers.
Let's do it.
But real quick, before we jump into the epidemiology, hit the follow button right now so you don't miss our future revision deep dives. And if you are serious about bulletproofing your exam prep, you need to get a premium subscription.
Yeah, that's crucial.
It's the only way to unlock our exclusive Journal Club and Clinical Cases deep dives. They are absolute game changers for the FRCS. All right, let's unpack this. We're starting big picture. Epidemiology and risk factors. What are the foundational stats that a resident absolutely must know cold when they walk into that exam room?
Okay, the first thing you need to lock in is that breast cancer is the most common cancer in the UK overall. Now, obviously rare in men, but for women, the lifetime risk of developing it in the UK is 1 in 8.
1 in 8? That's a massive demographic.
It is. It's the second most common cause of cancer death in women, right behind lung cancer, and the third most common cause of cancer death overall. But, and here's the critical trend that examiners want you to articulate, UK breast cancer mortality is actually decreasing.
Right, and that decreasing mortality trend is a great Viva question. They'll ask you to justify why that's happening, and it really comes down to 3 main pillars, doesn't it?
Exactly. You're looking at earlier diagnosis through much better screening programs, significantly more effective targeted treatments, and importantly, a documented decline in the use of hormone replacement therapy, or HRT.
And that mention of HRT bridges us perfectly into the risk factors. When an examiner asks you to outline risk factors, you need to categorize them logically. Let's start with reproductive factors. The unifying concept here is cyclical hormone exposure, right?
Spot on. The longer the window of exposure to fluctuating estrogen and progesterone, the higher the risk.
So we're talking about the bookends of a woman's reproductive life.
Right, so early menarche and late menopause. Both of those extend that window of exposure. And then you have to consider the impact of childbearing. Nulliparity is a recognized risk factor because the interruption of those hormonal cycles during pregnancy actually reduces long-term breast cancer risk.
And breastfeeding offers a protective effect, too.
It does. But conversely, if a patient have their first childbirth at an age greater than 30, that relative risk goes up. And as we just touched on, exogenous hormones are highly testable. There's a documented increased risk associated with both the oral contraceptive pill and HRT.
Okay, let's shift from reproductive factors to breast-specific factors, because this is a classic exam trap. Examiners love to test if you know the specific risk multipliers for different hyperplasias versus neoplasias. It's so easy to mix these numbers up under pressure. Let's break them down.
You have to be precise here. If a patient's biopsy shows atypical ductal hyperplasia, ADH, or atypical lobular hyperplasia, ALH, that pathology confers a 5-fold increased risk of developing breast cancer.
5-fold for atypical hyperplasia, but then you look at lobular in situ neoplasia, or LISN, and it jumps.
It jumps dramatically. A diagnosis of LISN confers an 11-fold greater risk. And the crucial exam detail, the one they will push you on, is that this 11-fold risk applies to developing cancer in either breast.
Either breast, not just the one where the LISN was found.
Exactly, so keep those distinct. 5-fold for atypical hyperplasias, 11-fold for LISN. Beyond those, you should also mention high breast density, which is a higher ratio of glandular to fatty tissue, a personal history of previous breast cancer, or early life breast irradiation.
And then we get to arguably the most heavily tested area in modern surgical oncology, genetics. We know 85% of women with breast cancer have no significant family history. But for the ones who do, you have to know the specific penetrance percentages. Let's lay out the BRCA mutations.
Right. BRCA1 and BRCA2 are the heavy hitters. They account for the vast majority of families with 4 or more affected members. In the general population, about 1 in 450 women carry a mutation in one of these genes. And remember, autosomal dominant inheritance.
But for the boards, you have to know the risk percentages by age 70.
You do. For female carriers of the BRCA1 mutation, you were looking at up to a 65% risk of developing breast cancer and a 46% risk of ovarian cancer by age 70.
Okay, and contrast that with BRCA2.
For BRCA2, it's up to a 57% risk of breast cancer and a 23% risk of ovarian cancer by age 70.
You really must keep those two profiles separate.
Right.
What about the syndromic mutations?
Just rapid fire associate these. TP53 gene mutation, associate that with Li-Fraumeni syndrome. PTEN gene mutation, associate that with Cowden syndrome. Both carry significantly increased breast cancer risks.
And just to round it out, always mention increasing 80% of cases are in women over 50 plus, increased body weight, lack of physical activity, alcohol, and Caucasian race.
Perfect.
Okay, so patient walks into your clinic with a symptom. Let's map out the triple assessment. This is the bedrock of breast surgery.
It's non-negotiable. Step 1 is clinical examination. Step 2 is radiological imaging. But your imaging choice depends entirely on age and tissue density. For women 50 to 70, the NHS screening program uses 3 yearly mammography.
But if you have a 32-year-old sitting in front of you, you're not ordering a mammogram.
No, classic Viva trap. Mammography is far less useful under 35 because young breast tissue is dense and fibrous, which completely obscures the imaging. So for under 35, ultrasound is your primary tool. It's great for differentiating solid lesions from simple cysts.
Where does MRI fit into the FRCS algorithm?
Not routine. You order an MRI if there's a discrepancy between clinical and radiological findings, or for very dense breasts. And high yield point here, if the core biopsy suggests an invasive lobular cancer, because lobular cancers are notoriously tricky to size accurately on a standard mammogram. You should also mention MRIA, which is a newer radio wave modality suitable for varying breast densities.
Then step 3 is the tissue biopsy, FNAC, or a needle core biopsy. Which brings us to histology. You have to know how to classify these findings. Let's start with a non-invasive versus invasive.
Non-invasive. The two big ones are DCIS and LISN. Ductal carcinoma in situ, DCIS, is dysplasia confined strictly to the epithelial cells of the mammary ducts. It hasn't breached the basement membrane. But if left untreated, up to 60% of DCIS will become invasive.
And LISN, which we talked about regarding risk.
Pathologists and oncologists view LISN as an incidental marker of increased risk, not an inevitable precursor. The actual risk of it becoming cancer is about 1% per year. But the clinical red flag is distribution. It's bilateral in 40% of cases and multifocal in 60%.
That widespread nature completely changes your surveillance counseling.
Absolutely.
Now, the invasive tumors, the breakdown is straightforward but critical.
Invasive ductal carcinoma is the vast majority, 80%. Invasive lobular carcinoma is roughly 10%. And the key exam fact for lobular, just like its in situ counterpart, is that it's significantly more likely to be bilateral than ductal.
Okay, receptor status. The modern management of breast cancer is entirely dictated by this. Why does receptor biology matter, and what are we testing?
It's the compass for your adjuvant therapy. We test 3 specific receptors. First, estrogen receptor, or ER. About 70% are ER positive, meaning the tumor relies on estrogen to grow. That's a therapeutic target for hormone-blocking meds. Second is progesterone receptor, PR. This is more about influencing the overall likelihood of disease recurrence.
And the third is HER2.
Right. HER2 positivity is in about 15% of early-stage invasive cancers. Historically, very poor prognosis and aggressive. But now we have targeted biological drugs like trastuzumab that attack those HER2 receptors.
And if the pathology comes back negative for all 3...
Triple-negative breast cancer lacks ER, PR, and HER2 targets. You can't use hormonal therapies or trastuzumab, which leaves these patients with a relatively poor prognosis.
All right, let's speed run the T&M staging. This is pure pattern recognition, and you need to know the numbers. Let's do the T stage.
Primary tumor size and extension. T1 is 20 millimeters or less. T2 is greater than 20, up to and including 50 millimeters. T3 is strictly greater than 50 millimeters.
So 2 centimeters and 5 centimeters are the pivot points, and T4.
T4 is any size, but with direct extension. T4A is chest wall extension. T4B is skin involvement ulceration, satellite nodules, or dermal edema, which gives you that classic peau d'orange. T4C is both chest wall and skin. And T4D is specifically inflammatory breast carcinoma.
Spot on. And N staging for the regional lymph nodes.
N1 is 1 to 3 axillary nodes, with at least one deposit larger than 2 millimeters. N2 is 4 to 9 nodes. N3 is 10 or more nodes, or spread to the infra or supraclavicular lymph nodes. 1 to 3, 4 to 9, 10 plus. Commit that to memory.
Okay, let's shift into surgical management and reconstruction, the absolute core for plastic surgery candidates. First decision point, wide local excision versus mastectomy. When is WLE indicated?
Highly selected patients with stage 1 or 2 disease, specifically tumors less than 2.5 centimeters. And you must say confidently that massive randomized trials prove long-term survival rates are identical for WLE paired with radiotherapy compared to a total mastectomy.
But what are the absolute contraindications for WLE?
Widespread, multifocal disease that you can't clear with a single excision. And practically very small breasts, because clearing the oncological margin would leave a severe cosmetic deformity. Mastectomy is better there.
Speaking of mastectomies, let's run through the classic classifications.
Radical, or Halsted, takes the whole breast, skin, pec major and minor, and full axillary clearance. Rarely done now. Modified radical takes breast and nodes, but preserves the pec muscles for reconstruction. Simple, or total mastectomy, takes the breast and nipple areola complex, but leaves the nodes.
And for a plastic surgeon doing immediate reconstruction, we care about skin-sparing and nipple-sparing mastectomies.
Exactly. For a skin-sparing mastectomy, or SSM, you remove 90 to 95% of the breast tissue, but preserve the skin envelope. You might use a WISE pattern to reduce that envelope if the patient is peptotic.
And the nipple-sparing mastectomy, NSM.
You preserve all the skin plus the entire nipple areola complex, the NAC. The oncological risk is local recurrence right behind the nipple, so a frozen section biopsy of the subannate tissue is mandatory during the procedure to confirm clear margins.
And the recurrence rate data for NSM.
Case series show a 3 to 6% local recurrence rate at 5 years, highly comparable to traditional mastectomies.
Okay, scenario time. Patient just had an SSM or NSM. What are the classic immediate reconstructive options you list for the examiner?
4 core pathways.
Subpectoral implant or expander with a cellular dermal matrix, ADM, for inferior pole coverage.
Implant or expander beneath a pedicled latissimus dorsi flap.
Extended latissimus dorsi, ELD, flap with or without lipofilling.
Autologous free flap using abdominal tissue, so de-epithelialized tram or DAP flap.
Perfect. Let's move to the axilla. Getting this sequence wrong is a very easy way to lose points.
Yes. Start non-invasively with preoperative axillary ultrasound. If it's negative, you must still stage operatively using a sentinel lymph node biopsy, SLNB.
With the standardized technique.
Dual modality, injection of radioisotope and blue dye to map the lymphatic drainage.
And if the SLNB is positive.
For macro or micrometastases, standard indication is to proceed to a formal axillary clearance. We prefer this over primary radiotherapy here because it provides definitive histological staging.
And your anatomical landmarks for clearance.
Levels 1, 2, and 3 of the axilla, defined by the pectoralis minor. Level 1 is inferolateral to pec minor. Level 2 is directly posterior. Level 3 is supermedial.
Okay, to finish the clinical picture, you have to understand systemic therapies for the multidisciplinary team meetings, rapid-fire adjuvant therapies.
4 pillars. Radiotherapy for primary invasive or DCIS with breast-conserving surgery, or post-mastectomy with high-risk features like a tumor over 5 centimeters, involved margins, or 4+ positive nodes. Chemotherapy for node-positive, large, grade 3, or triple-negative tumors.
And the targeted ones based on receptors.
Hormonal therapy for ER-positive. Tamoxifen acts as an antagonist. Aromatase inhibitors for postmenopausal women, but they cause bone density loss, so you absolutely must monitor with DEXA scans. Finally, biological therapy trastuzumab for HER2 positive.
That is an immense amount of high-yield data. As we wrap this up, I want to leave the listener with a final provocative thought regarding patient communication.
Yes, this is about prophylactic nipple-sparing mastectomies for high-risk patients, like a BRCA carrier. As surgeons, we must counsel this strictly as a risk-reducing procedure, never as cancer-preventing. Because anatomically, even with flawless technique, a microscopic amount of ductal tissue inevitably remains adhered to the deep surface of the NAC. The risk is drastically lowered, but it is never absolute zero. Precision in technique is expected, but precision in counseling makes you a master surgeon.
That is exactly the nuance examiners and patients are looking for. All right, residents, that is your comprehensive FRCS deep dive on breast cancer management. If you learned something valuable today, rate the show right now and leave a comment specifying exactly which FRCS topics or anatomical regions you want us to dissect next.
We check all those comments.
We do. And do not leave your prep to chance. Go get a premium subscription today to unlock the Journal Club and Clinical Cases deep dives. Keep studying hard, trust your training, and we will catch you on the next one.